members. Welcome to another Facebook Live. I want to go ahead and discuss some important questions that patients have asked me. I have clinic on Mondays, we'll talk about a couple of my patients that came in today. One of the most interesting patients that I've seen today was a nice lady, 69 years of age. She had her first implant done in 1983, and this was silicone above the muscle, 160 cc's on the right, 140 on the left. And then what happened was in 1995, she was noted to have what was a ruptured implant on the right and also on the left. And then she ended up getting saline implants below the muscle. Then later on in the year 2005, she ended up getting her third set silicone implants, and they were to replace the second set saline, which had both ruptured because of the capsular contracture. And the surgeon, what he did was tried to do what is a closed capsulotomy. Closed means the patient was not taken to the operating room, there was no incision made, and capsulotomy means what there was the capsule became hard like an egg, if you will. And so the surgeon, what he did was he pressed on the implant capsule such that he would ultimately break the capsule and it would not be hard, just like an eggshell, if you will, and it would become relatively soft and acceptable. And so this is what the surgeon did, unfortunately. And so the third set was eventually removed in 2011, which was noted to be ruptured. So this is her second ruptured implant. And then in 2015, eventually another surgery. And the bottom line here is she had a total of 6 surgeries. The first surgeon did 1, the second surgeon did 2, the third surgeon did 3. And she had what were masses that were notable on her CT scan, to the point where she ended up going to the top 5 hospitals in the United States. And lo and behold, did a biopsy of this neck mass, and it turned out there was silica in the lymph nodes. And this is where that implant that had ruptured times 2 had spread, extravasated into the periphery, and she has a CT scan, a PET scan showing lymph nodes in the armpit axillary area, lymph nodes in the subpectoral region, lymph nodes in the neck, and literally the extravasation of this ruptured silicone that has gone to the periphery. And now she has an MRI from 2022 that shows that her latest set of implants is 500 cc's, and it's ruptured intracapsular, extracapsular, and it is also prominent. Lymph nodes are present in the axillary armpit region. So she has essentially 4 big problems going on, if you will. A very complex case. Number 1, she has to have that residual capsule plus that spill silicone above the muscle that needs to be removed. She has what are relatively very large implants, 500 cc's, that need to be removed. Number 3, she has a current set of implants that are both intra and extracapsular ruptured, as proven by the MRI. And number 4, she has had a total of 6 surgeries with a lot of dissections, lift, cut around the anchor incision at the bottom of the breast, with a lot of inflammation, with a history of 2 spilled silicone implants. And she's 69. Now, the bottom line here is all of that needs to be cleaned out, and we're looking at least a 5 to 6 hour surgery. And each one of those is a challenge to do. And this is where, having taken care of a lot of patients, I've broken it down. She's going to go and get the medical clearance. I've already looked at the MRI, and we'll proceed with surgery, and hopefully we'll do the Facebook Live one day. And again, what bothers me is the fact that she had the ruptured right and left breast implants as seen at this major top 5 institution of the United States. And this patient was not seen by a plastic surgeon at that top 5 institution, and she was not made aware of the fact that she needed to get these implants very much removed, along with all what was discussed in the en bloc fashion, 100% total residual capsulectomy plus the spill silicone, and that this workup was needed to be done. So again, this is very, very I use the word unfortunate, I use the word literally millions of people who have had implants for many decades, and they have ruptured implants and they do not know what to do and they're hurting. And she had a lot of complaints, as you can imagine. And this is essentially goes on to showing you that implants are not lifetime devices. Again, these are not my words. And this is where if you're hurting and you have capsular contracture and you have chronic pain and you have basically a lot of hurt and misery from the signs symptoms of breast implant, unless I want you to know that there's relief available and that there is a certain etiquette and finesse into doing the surgery completely definitively. And so if you've come to me, you will see the entire implant capsule, all inflamed tissue badness will be removed. The residual capsule will be removed. The spilled silicone will be removed. And no matter what the size of the implant will be removed. And it will be done in a very thoughtful, systematic way. And whatever is removed is going to be tested so we know what it is and what it is not. The other thing I want to discuss here is, one of the other patients mentioned that, she had, her explant surgery done, if the muscle repair was done or not. So this is a very good question. And, thanks to Mar, you will see this is a picture of the pectoralis major. Can we see it on the cameras?
Mm-hmm. Yep.
So this is the pectoralis major, if you will. The red arrows signify what is the origin of this muscle. That's where it's anchored in. The insertion is this blue arrow in the upper arm. So let's say if your surgery is done today, you can type, text, because you're not really using your upper arm, you're just using your wrist and digit. So for example, if your surgery is done today, you could type text, you could drink a cup of water, you can sign a document next week. So most of my patients who have a desk job are back to work, typing, writing. But if you are a nurse or you're a flight attendant and you have to lift heavy objects, or you are someone as an engineer who has to climb ladders, you will see the muscle inserts into the upper arm, so you have to be T-rexed for that reason. So that day that when the surgery is done and the implant is placed below the muscle, no one cuts here, here, here. They cut down here. And I want you to go to YouTube and type in subpectoral, that means below the pectoralis major muscle placement. So as you will see, the surgeon makes a cut down here at the bottom. And because the cut is made, the implant is then put underneath this muscle. So if you can imagine, this is the muscle, the breast tissue is above the muscle in vast majority of the cases, and any good reputable board certified plastic surgeon will put the implant below the muscle. So the surgeon makes the cut here, and I'm going to go ahead and draw it out. So the surgeon makes the cut along this where the X's are. And if you can imagine, if it's a 160cc implant like this patient had today, the surgeon makes a small cut. If the patient has 450, like my very last patient, there is a lot more cut to put the implant underneath the muscle, and the muscle is cut here. And you can imagine if the muscle is cut here, this compromises some of the function of this muscle because the muscle has been cut. And then the surgeon puts the implant underneath the muscle. Now we're going to call the space underneath the muscle P2, just for simplicity's sake. The area above the muscle is what I'm going to call P1. Now the breast tissue is located above this muscle. So if you look at the anatomy, the nipple areola is here. You got the breast tissue. You got this muscle. The breast tissue is in P1 category, P1 level. And then below this muscle is P2. So the entire implant capsule is below. So in my practice, I'm always below the muscle in P2 level. So I never cut around the nipple areola. I never cut up and down. I only make that horizontal cut that's going to hide right in the crease, such that I can go in and be in the P2 level. I do not go to P1. I do not want to distort the anatomy of the breast. I do not want to distort the anatomy of the breast when the patient does their self-monthly breast exam. I do not want that to be altered when the patient gets their mammogram. I do not want to be cutting into the breast tissue up and down or cutting around the nipple areola. Patients have reported loss of nipple sensation, pins and needle sensation of the nipple. Some patients have reported an indentation of the nipple areola because the cut was made. So because bacteria live in that nipple areola ductal systems, there is sometimes seeding of the bacteria that can occur. So I don't like to cut around the nipple areola and up and down, because that simply can be avoided by making a cut right in the crease. So I'm always below the muscle, which is the P2 level. Now, as you can imagine, that was a cartoon picture, but this is like a cadaver picture, and you will see the surgeon makes the cut down here at the bottom. So I'm going to go ahead and draw a line where the surgeon makes a cut to place the implant below the muscle. And so the larger the implant, you can see the larger the implant, the larger the cut, in order to put the implant below the muscle. Now, as you will see, if you cut the muscle right here, the muscle retracts, it kind of window shades up, and if you can imagine, you put the implant underneath, you cannot take the muscle and cover the entire implant and secure the muscle down at the bottom. It simply cannot be done. This is why breast cancer patients, when they get their tissue expander, they make the cut right in the middle of this pec. They put the tissue expander underneath, maybe put 30, 50 cc's, and then they close the muscle. And then every month they put in 70, 100 cc's till the muscle expands. And then the patient comes back the next month. They put more fluid into the saline implant on the cancer patient, and then it goes to 200, 300, 500. And then they remove the tissue expander and put the implant after expanding the muscle. In the cosmetic patient, the cut is made and the implant is put underneath this muscle, because any good reputable board certified plastic surgeon will place the implant below the muscle. Now, when this muscle is cut, the muscle quote unquote window shades up. And if you lift this muscle, you will see the muscle retracts, and now the implant is literally sitting over here if it's placed appropriately below the muscle, and down here. Now, what happens over time, if you contract the muscle or the gravitational pull of the implant down, it just literally bottoms downward and outward in this vector. And so over time, you will see the implant literally ends up moving from this location down here. It just bottoms downward and outward. So you will see most of the implants start going towards the side, and if you rub your arms against the side, you will see you'll be rubbing into the implant, and it is relatively very common. If the implant is placed above the muscle, this happens more so because there is no muscle technically holding it. Now, as soon as I make the cut here, I'm always below the muscle in the P2 category. I do not go to the P1 category. This weekend, I talked to a patient who is going to be nursing, and this patient is going to get her surgery done, and she can nurse all what she wants because the breast tissue is above the muscle. I'm not going to touch it, and I'm always going to be below this muscle. And this is where I make the cut, and I'm bending my neck, and I'm dissecting in that bloodless avascular plane underneath the pectoralis major. So I always stay again below the pectoralis major muscle.
Just a quick question from a patient or potential patient. So what happens if the surgeon placed it above the muscle?
So the muscle is not cut, the implant is placed above the muscle, and so you're essentially done. So there is no cut into the muscle, and the muscle is essentially left as is. This is where the bodybuilders or the active moms who are working like as a yoga instructor, they do not want to compromise their muscle. They get their implants above the muscle. And this is where the surgeons usually ask young moms if you're active, how active you are, and they would not want to cut the muscle. The moment you cut the muscle, you compromise the function of the muscle. So again, going back to the point, the implant just moves downward and outward, and as soon as I make the cut, I myself, I'm finding the implant is like literally gravitating down, hanging down, and when you use your muscle, you squeeze the implant downward and outward. So as soon as I make that horizontal cut alone, you will see I'm always below the muscle. I never touch the breast tissue, and I'm always below the muscle. Below the muscle, if I remove this muscle up, all what you have is pec minor, which is this purple muscle, and you got the ribs. So there is no precious volume that I'm removing. And this is the pec minor, which is left as is. So going back to this, I'm always below this muscle, and it is relatively tough and hard. One of the other very prominent explant surgeons was saying it is a lot of strain and stress to the neck to be able to go like this and to operate in a small cave usually. And this is where, yes, it is tough and hard, but at least I do not cut into the breast tissue. I do not cut the muscle up and down in order to split open the breast tissue as a book. I always cut horizontal in the crease where I hide my incision in the crease, and I'm always below the muscle. And yes, it is tough to dissect all the way up, and normally any good plastic surgeon will place the implant 2 finger breadths below the clavicle, and this is where up to I'm dissecting to. And the bottom line here is do not touch the breast tissue. And so a patient came to me and say, hey doc, I have small amount of breast tissue, what happened? And I said, guess what? I did not touch the breast tissue. Genetically, you did not have much breast tissue, and this is how God made you, because I do not touch the breast tissue. And the other thing is, I do not cut the muscle up and down. So I'm always below the muscle. So that muscle is essentially preserved, and that muscle was cut by that previous initial surgeon. Now, in my practice, I have seen a patient, for example, from Hawaii, where the surgeon was so smart and clever, and this was like almost a 5 feet 11 inch tall patient where she had a very large muscle, and the surgeon put in 200 cc implant, and you can just cut here and put the implant underneath and secure it, because in that case I repaired the muscle. There's another patient from Indiana. Her surgeon put in very small implant, and in a very smart, clever way, without cutting the muscle, was able to put the implant below the muscle, and I absolutely repaired the muscle. And the muscle absolutely must be repaired, not only for function, but also for aesthetics. You get a better aesthetic result. Now, all these years, the patients have had implants. They truly cannot use their muscle effectively. Number one, it was cut by the previous surgeon. And number two, the implant is getting in between the muscle and the rib. So if you lift something heavy, you're going to squeeze the implant in between the pec major and the rib, and that's going to be a very awkward feel. And that's why when patients start to flex and move their arms, you will see the implant bounces up and down. And this is very analogous to a male bodybuilder or a female bodybuilder with no implants, and they flex their pecs on the stage. In this case, the young mom who flexes her muscle will flex the implant as well, and it's a very awkward feel. And so the patients learn to choose not to use the pec function, because it shows it's an animation deformity, dynamic deformity, as you bounce the implant around. And so for the same reason, nowadays, what is a very hot selling implant is the Motiva micro-textured implant that's placed above the muscle through a small incision under local. Now, I will say this, micro-textured automatically is a red flag. The fact it is a silicone implant is a big red flag. The fact it is above the muscle is a big red flag. The fact that this is being sold as safe is a big problem in itself. Remember, at the end of the day, it's implant silicone. It's a not lifetime device. It's micro-textured, and the fact that it is textured in itself leads to more inflammation. Now, so far the studies are showing that they're nice and safe. Guess what? We will see there is no true long-term data. This is being propagated by the insurance companies and being sold as safe. And this is where the patients have to realize there is no such thing as a safe cigarette, correct? Same thing, there is no such thing as a safe implant. And I guarantee any of these plastic surgeons to say that these implants are safe, long-term safe, that they do not need to be replaced 10, 15 years later, maybe sooner. And remember, you do not want that implant to leach silica into the periphery, into the lymph nodes, and that is going to be a major problem if that does occur. Now, not my words. As you will see, this is the guidance for Industry, Food and Drug Administration staff issued by the FDA, not my words, again, September 29th, 2020. And as you will see, this is the instruction that they have on implants. Page 14. I understand that silicone can migrate from my implant into nearby tissues, chest wall, lymph nodes under the arm, and organs, liver, lungs, where it may not be possible to remove. I understand that all breast implants contain chemicals and heavy metals. I understand that most of these chemicals stay inside the shell of the implant, but small quantities have been found to diffuse gel bleed through the implant shell of silicone gel-filled implants, even if the implant is intact and not ruptured or leaking. So the point here is even these Motiva microtextured implants are going to be a nuisance and a problem ultimately because they are going to leach. They're made up of silicone. And so there is no such thing as a safe silicone implant because they're not lifetime devices. And this is where you as a patient want to literally review and the records of what is the black box warning, what are the manufacturer's warnings. And unfortunately, right now, a lot of patients are falling into the trap where these are the safest, the nicest, the best sixth generation microtextured Motiva implants. And I will tell you from my humble opinion, absolutely 100% not. There are another type of poison being sold as safe. You want to do your homework and your due diligence so that you know what you're signing up for, and you want to basically do your homework as you determine what is it that you want to do. Now, please go ahead and feel free to ask me any questions between TikTok, Instagram, YouTube, and Facebook. Yes, please.
From TikTok, will everyone develop breast implant illness?
Not everyone will develop breast implant illness. So let's go ahead and talk about this. So this is the same black box warning that is present in every catalog, every manufacturer will share and plastic surgeon will share with you. You can certainly Google this. Patients receiving breast implants. So this is the black box warning. Patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others. Individual patient risk for developing these symptoms has not been well established. Some patients report complete resolution of symptoms when the implants are removed without replacement. This means, number one, let's break this down and I'll translate for you. Patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others. Number one, they're telling you breast implant illness absolutely does exist. So we don't have to listen to someone who says, I published a paper, it does exist. We know it exists because they're telling you the black box warning. The patients are telling you that they are benefiting from an explant when they remove the implants, their brain fog, fatigue. Today, I saw a 42-year-old patient. She's been to the cardiologist. All the test, lab workup, everything has yielded nothing. She's even been to a rheumatologist and they said, excellent bill of health. And she has all these complaints that she has checked off. This is a diagnosis of exclusion. So in her case, if you look at her symptoms, all of the workup is negative. No lupus, no rheumatoid arthritis, no Hashimoto's, no MS, no Lyme disease, no palpitations, no arrhythmias, no AFib. And now they're telling her, go take psych meds. And now she's like, I know I have breast implant illness. And this is where you have a diagnosis of exclusion. No one walks into my clinic and says, my implants are making me healthier or better, or I'm able to jump higher, or I'm able to think sharply, or the implants help me pass my boards. If anything, it's only bad. My joints hurt. My fatigue is worse. I cannot get out of bed. I have pins and needles in my fingers. I have palpitations. I have anxiety. I have ringing in the ears. I have migraine headaches. I have neck, back, fibromyalgia. So now there are patients that I've seen where they have no complaints, not a single symptom checked off, and lo and behold, they have what is a ruptured silicone implant on their left side. You would think they would at least exhibit some sort of a problem. And this is where this is a very mysterious illness, and it's a very evil illness. Evil in a sense that you have a ruptured implant, at least you should be in pain, or you should have some redness. Let's go ahead and look at the mentor advertisement. This is the back of a journal that we read. You will see the moderate, high profile, connect with a representative about the full lineup of mentor memory boost breast implant options. Here's that same black box warning that I just read. And then you will see down here the mentor advertisement. They have their nice address here. And you will see the fine print. It says, quote, MRI screenings are recommended 3 years after initial implant surgery and then every 2 years after to detect silent rupture. Silent rupture means the exam is like excellent, but the patient has a ruptured implant on an MRI. And this is where not all the patients have BII. Now, this is where, let's say, if 100,000 patients who are 25 years of age get silicone implants, all 100,000 of them, plus minus 10 years, will need to get them replaced, hopefully removed, because remember, they are not lifetime devices. Now, why do we know this? Let's go ahead, not my opinion. It says the first part, breast implants are not considered lifetime devices. The longer people have them, the greater the chances are that they will develop complications, some of which will require more surgery. So if 100,000 patients get implants, they will not live with them into their 30s for 20 years, 30 years, 40 years, because remember, they're going to rupture. And you have seen the many ruptured implants. Last week, I did a total of 12 explants between 6 patients, and 50% of them were ruptured. That means 6 out of the 12 implants that I removed last week between the 6 patients, 50% of them were ruptured, 6. And you can see the Facebook Lives. And the point here is, you never know. There was a patient who had implants from 2011. So she had a rupture. These were supposed to be the nicer, better, safer gummy bear. And I'll tell you, there was nothing gummy between her 2 implants that were completely disintegrated. And I want you to see the Facebook Live for yourself. There are patients, let's go ahead and look at the risks that one can have. So going back to this, again, this is the FDA, good communication between, what's ironic about this is it tells you breast implants, certain labeling recommendations to improve patient communication. I want you to Google this. It says guidance for industry and Food and Drug Administration staff. It should say guidance for patients. Because what happens here is, if you look at, all these risks that are listed, for example, on page 11, risk of breast implant surgery. I understand that there are risks of undergoing breast implant surgery. I understand that risk of undergoing breast implant surgery may include breast pain, skin or nipple areola sensitivity changes or loss, asymmetry, impact of aging or weight change, infection requiring possible removal of implants, swelling, scarring, fluid collections, hematoma, tissue death of skin or nipple, inability to breastfeed, complications of anesthesia, bleeding, chronic pain, damage to surrounding tissue such as muscle, nerves, blood vessels, impact on imaging of breast tissue. And then they want you to initialize here at the bottom that you were told this. It says, my physician has discussed the potential use of other implanted products during my breast implant surgery. And they want you to patient initial with the risk of the rare BILCL. As you will see on page 14, I understand that the long-term risk of breast implants may include painful or tightening of scar tissue. This is the capsular contracture, rupture or leaking of the implant. Reported in up to 31.2% of the patients. And again, you have to read between the lines as to how long of the study they did. Wrinkling of the implant, visibility of the implant, shifting of the implant, need for reoperation. Ultimately, they're seeing autoimmune disease in others. You're talking about rupture, displacement, one problem after another. The other thing I want to read off here, page 14, again, not my words. I did not type this. This is from the FDA. I understand that all breast implants can interfere with mammography and breast exams, which could delay the diagnosis of breast cancer. Mammography can also cause the breast implant to rupture or leak. Just what I have read, if you are someone who is thinking about implants, you should run as fast as possible away from the implants, because as you can see, who would want this in their body? They are only replete with problems. Sooner or later, you will have a problem. And this is where you have to think smart. You have to think long-term. You have to think 10 years, 15 years, maybe sooner, maybe later. The longer people have them. I talked to a patient last week. She had implants only 2 years and her problems started occurring. There are patients that have come to me 44 years later. This is the patient I took care of last Thursday, and I did her explant, and she, God knows, had ruptured implants, God knows, for maybe decades. And the bottom line is, no one should have to live with this uncertainty, right? And it's only a negative uncertainty. It's not like a small subset of patients who are going to have problems. So I was talking to another very prominent plastic surgeon, world renowned, and I told him if 400,000 patients per year in the US get implants, eventually 10 years, 12 years, 15 years, maybe 7 years later, they will all need to get that at least replaced, hopefully removed forever. And the bottom line here is these are not safe devices. Who wants silicone leaching into the periphery like that nice 69-year-old patient that I talked about earlier? Who wants to have a ruptured implant? I took care of a patient last week. She had implants from 2019, just 7-year-old set of implants, technically 6.5, and she had a ruptured implant, and it indeed does occur. The other question to ask, and this is for my patients, and I won't answer for you. If you get an MRI and it shows it's not ruptured, do you want to wait 2 years to find out it was ruptured and then remove? Who knows, there might be more of a silicone spill into the chest. And I say to you, if you're interested in getting implants, please know what you're signing up for. If I see 100 patients, 99% of them have no clue what they signed up for, which is a major, if you ask me, informed consent violation, because the patients have no idea what they're signing up for, or the surgeon is downplaying the risks of getting implants. And remember, saline implants cause the same hurt as silicone implants because the silicone shell of that saline implant imparts the same toxicities, reactivities, the histiocytic giant cell reaction as patients who have silicone implants.
I do have a question from TikTok. What about hip or knee implants?
So that's a different issue. Remember, they're titanium, stainless steel. There are patients who have those forever. And as you will see, there has not been much of a report in the past. If you look at silicone implants alone, look, they were banned in 1992 to 2006, the latter part of it, for a reason. And this is the same reason why these implants are disintegrating, rupturing, and harming the patients. And as you can see, those patients that got implants in 2007, 8, 9, 10, 11, now are coming forth with their ruptures, complaints, because they were in the dark about the need for removal or replacement, right? And remember, if someone has a ruptured implant, it is not normal or healthy to be living with a ruptured implant. Vast majority of the emergency room doctors, primary care doctors, family medicine physicians, PAs, nurse practitioners, who are the primary care providers, have no clue what it means to have saline implants and silicone implants. And unfortunately, they are sold as very safe. Breast implant illness is not a myth because all those patients who have complaints, they are not a myth.
Dr. Khan, will 6 weeks of T-Rex arms cause complications resulting in physical therapy?
So absolutely not. As you will see, just the fact that someone has had their muscle cut, just the fact that they have implants below the muscle, just the fact that they may have a capsular contracture in itself, each will separately lead to problems with the neck, back, shoulder, fibromyalgia issues. Now, in a surgery like this, for example, someone gets a tummy tuck. They're not exercising. They're not moving about much. They're not doing the treadmill. They're not working out aggressively, right? Because you're not supposed to. You're not going to feel the hurt for the 6 weeks of not working out. If anything, once the surgery is done, your shoulder, neck, back posture is only going to be improved. Now remember, almost 80-90% of my patients, day 6, day 7, day 8 are driving. Once they're off the pain meds, their reaction time is good, and they feel comfortable and confident, and they're off the pain meds, they are driving. As you can see, it's slow motion movement of the upper arm because you do not want to use your pec major muscle, as I showed you. And you are doing your own, making your own coffee, you're making your own sandwich. If you have a desk job, you're back at work at 3 weeks. People at 6 weeks, 90% of them, if not more, 95% of them are gently doing 2-pound weights, 1 minute in the morning, 1 minute in the evening, and now building up on the muscle. So in 6 weeks, you really don't lose anything, and you're kind of moving your arms. all those years that you had the implant below the muscle, or you had a capsular contracture, or your muscle was cut, that was the bad time that you had where you truly were not using your muscle. The muscle atrophies because anytime you use the muscle bounces the implant around. It's an awkward feeling. Sometimes you cannot even compress the muscle against the rib because it hurts. That is the loss and the compromise you have. Another way to look at it, look, you have a rotator cuff tear and the patients are like this for 3 months because they have to let that rotator cuff heal maybe 8 weeks, 12 weeks, 10 weeks, and the patients still bounce back. This is only short-lived 6 weeks, and if anything, you come back better than ever before. So your pickleball game, your golf game, eventually your upper strength is going to be only better. And so when you do start at the 6-week mark, it is a self-guided recovery. So you do not want to feel the burn. You want to kind of go slow, and you will see the second week you do 2 minutes 2 times per day with the 2-pound weights. Third week 3 minutes 3 times per day, and now you're actively building the muscle mass. In a couple of months following that, you're going to be doing upper yoga, neck, body, shoulder exercises, and you're going to build not only on the pec major, but the pec minor, the serratus, the latissimus, the deltoid, the suprainfraspinatus, the trapezium, all of these muscles of the neck, back, shoulder that were compromised, and your posture is going to be better than ever before. Your neck, back pain problems, fibromyalgia issues are going to be better. And so I will tell you with absolute confidence, you're not going to have a frozen shoulder. Those patients that have had problems with their shoulder because of a torn labrum or a rotator cuff tear or previous 3 surgeries on their shoulder, they already have problems. They might have a little bit of a problem holding a T-Rex, but you have to let yourself recover. If someone gets a knee replacement and they're going to be sitting still for 6 weeks, 8 weeks till they start doing the therapy, do you think we should not do a single knee replacement because they're going to have atrophy of the muscles of the leg? No, you have to let the recovery occur, and then you're going to come back and start building on the muscle mass. You lose muscle mass over 3 months, 4 months, not over 6 weeks. And you have to let the recovery occur and happen. 50% of the recovery is the surgery. The other 50% is the recovery. If you get the best knee replacement and you start walking on it at week 3, 4, 5, you're going to have problems. Same thing after the surgery. You get the surgery done. Remember, this is a relatively very invasive surgery. If you talk to 100 plastic surgeons, 90 of them don't want to even hear the word explant, end block, total capsulectomy, and the other 10 probably would not even do the surgery correctly. And the point here is, do the surgery once, do it right, do the best recovery, and ultimately you're going to have the best bounce back that you're going to ever have, because you have to listen to the instructions so you're not going to run into problems.
When can I start exercising after explant?
So you will start a gentle regimen slowly. If your implant is above the muscle, maybe at the 4, 5, 6 week mark. If you are below the muscle, it all depends. So last week on Thursday, I took care of a patient who had 600 cc implants, extremely large implants, sitting over at least 6 ribs, both ruptured and extreme inflammation and extremely thin skin. Her recovery is very different than the other patient that came from overseas with 170 cc implants above the muscle and a surgery that was done in a very nice way from that very thoughtful surgeon done overseas. These are 2 different patients. Another way to look at it is, one of my other patients came, she had 350 cc implant and she had a tie around her arm. She listened to my instructions, and at the week 6 mark, she progressed very nicely and very definitively and very sincerely forward. Another patient came in at the 2-3 week mark. She started moving her arms. She got into her F-150. She's climbing up. She's working 12, 16-hour jobs. And she's literally running around as if she never had her surgery. At 6 weeks, at week 3, I tell her, you have to contain yourself. At week 6, she's still like, I'm still sore. And guess what? She got restricted, limited by another 3 weeks by me because I cannot move her to the next level. So you have to let yourself recover optimally before you move on to the next level. Again, this is the etiquette of the surgery. If you get a tummy tuck and then next 3 weeks later, you're doing sit-ups, push-ups, you're only going to aggravate the recovery, cause more problems. And this is where you have to listen to the instructions. You don't have to listen to the patient who has no idea what the surgery even meant, if it was above, below, ruptured implant, what was the size, was it done by a reputable surgeon, what was the level of inflammation, was this the sixth surgery that the patient had or the first surgery, was this a capsular contracture, was this a patient who was radiated. So you have so many variables, and again, the direction comes from the surgeon. At the end of the day, your bond is with the surgeon. I find a lot of patients that were seen elsewhere, they only saw the surgeon before once on the day of the surgery, and they never saw the surgeon. In my practice, you see me before. I'm very much hands-on before, during, and certainly very much after. I only know what happened inside the operating room, and that's why only I give the instructions. And as you will see, I'm very much involved in this whole overall process of recovery. And the surgery is extremely important. The recovery is extremely important. So you have the best and the smoothest course and optimal results post-op.
What happens if I accidentally lift too much and become sore after explant?
So you cannot do that because you're going to put a tie. This is just like saying, what if I start walking on my knee replaced, my knee that was just replaced, or my rotator cuff, I start moving my arms out. No, you put a tie around, and that's the ultimate and the only way, is because you're not going to do it. And if you're not going to do it, you don't have to deal with it. Now, a year ago, someone fell on ice. Now, that's an accident. I want to know about it, right? But if you can imagine, everyone is moving their arms out. Oh, I feel good. Like I saw a patient today, she's 7 weeks out. She literally was, I can do everything. And I said, who told you? He said, because I thought I could. I said, those were not the instructions. And she took chances. And she had extensive intra and extracapsular spread, extreme amounts of inflammation, ruptured implant. It was a very involved case, the top 3 most involved cases of 2025. And she was moving her arm around. I will tell you, it made me mad that she would disregard my recovery for her own. This is where the patient ultimately will end up hurting herself. This is not for me, I wish I could make everyone run a marathon the next day, but remember, this is where you have to invest in your recovery. You do not want to take any chances, and the smarter patient is the one who listens to the instructions. There was a patient that I talked to, she had 3 kids. She said, my husband's always flying. I'm usually the caretaker of my 3 kids. I have to put them in the car seat and take them to school, and I don't think I can do that. And I said, then I'm not your surgeon, because I don't want to have to deal with a complication. This is just like saying you're going to get a tummy tuck and you're telling your surgeon, I'm going to do sit-ups because I feel like I'm going to lose my muscle mass. No, you have to listen to the instructions so you get the best recovery possible.
Is saline safer than silicone?
So saline implants causes the same hurt as silicone implants because the shell is silicone. Those silicone particles are leaching from the silicone shell of the saline implant, and they're basically going into the periphery. So if I have 1,000 patients that have come to me with complaints of saline implants, those are interchangeable with the 1,000 patients with silicone implants. So you cannot tell by listening to a patient, oh, you have saline implants or you have silicone implants from their complaints. And so the bottom line is when they banned the silicone implants, they should have banned them for reconstructive purposes from the year 1992 to 2006. They should also have banned saline implants, and so that none of the patients would have had to suffer. So the same complaints like suicidal ideations, joint pain, brain fog, dryness of the eyes, heart palpitation, and all these other problems that the patients with silicone implants have, patients with saline implants have essentially more or less reproducible complaints such as this.
Is there any natural breast enhancement options?
So the bottom line is you have to replace with volume. Fat grafting is a horrible idea, and I have used the word malpractice. Some of the fat will form clumps of dead fat and may deposit around nerves and may cause acute and chronic pains. Oil cysts may form. Fat may take on the side, not on the medial. Now you may have an indentation. You will have problems, complaints of patients who basically report acute and chronic pain, altered sensation, not only at the donor site, but the recipient site. And sometimes these clumps of dead fat may occur, fat necrosis, in 1, 2, 3, 5, 7%, depending on the size that is injected, the technique. and now you may have a self-monthly breast exam that might be picked up on masses, and you will not know if it's breast cancer, if it's fat necrosis, it's the scar tissue or nodular fat that did not take, and now you're getting anxiety about if this is breast cancer or biopsy that may they may want to do, and they may not feel comfortable because it's in the proximity of the implant. So I have the top 5 plastic surgeons in the US. One of his patients came to me not too long ago, and she had what was a mass right next to the implant, and they were concerned if this is breast cancer or if this is fat necrosis from the fat grafting that she had. And they wanted to do a biopsy, but they said they're concerned they might puncture the implant. And now the patient's getting very anxious if this is breast cancer or not. They don't want to wait 6 months to do another mammogram or another MRI. And she's very concerned. So she came to me and she said, I want an explant done, and so that I can get this biopsied, or if you can remove this mass. And the bottom line here is this is a real problem. Yes, it does occur in a small subset, but you never know if it's going to be you. And sometimes the fat grafting may need to be done 2 or 3 times in order to give the desired volume. And fat grafting to the breast tissue, in my practice, I call malpractice, bad in the medicine. It should not complicate. 1 out of 8 or 9 women who will get breast cancer, we do not want to complicate. There are patients that I've seen with fat grafting who have pins and needle sensation around the nipple, or a hard mass because this is how the fat took, or unevenness, fat took on this side, not on the other, and now the patient does not want to do it. Many patients have reported it was a horrible idea clinically, and you listen to the patients. Now the surgeons will swear that this is a good replacement model, but I will tell you, not in my eyes. The other thing in the breast cancer patients, you can take the fat from the belly or other areas and then put it up on the chest, which is the deep inferior epigastric perforated flap or other flaps. Remember, these are relatively invasive for the breast cancer patients, and you have to seek that surgeon out. Just like everything, they have a risk and balance. Now, the bottom line here is do your homework, do your due diligence. Listen to what the FDA is saying, listen to what the manufacturers are saying, and most importantly, listen to what the patients are saying. You do not want to sign up for a procedure that there is a lot of unknown. There are question marks about the health, long-term implications, sometimes permanent implications about silica that might be present in the lymph nodes. So that very first patient I discussed, I told her I'm going to remove everything, clean out everything, but the lymph nodes in her neck, in her axillary area, which have been lit up because of the CT scan that shows axillary lymph nodes, and a biopsy has been done that shows silica, and then unfortunately I'm not going to touch that, otherwise the patient's going to get lymphedema. And the bottom line here is you really want to do your homework. You want to listen to what the patients are saying. Implants ultimately are not safe devices. The whole goal is do no harm. Do no harm to your body. Don't sign up for something where there's a lot of mystery, unknown, and only ultimately badness that is related to the implants. This is not in small subset. Eventually, everyone will succumb to some problem that the implants will cause because they are not lifetime devices. And you as a patient who has implants need to be aware that if the problems do arise, you have to strongly consider what we already know. If you are thinking about getting implants, you really need to know what you're signing up for. And again, this is part of informed consent. And this is not like a small subset. This is eventually everyone, because they're not lifetime devices. So the other thing I want to mention here is it's very important to go to someone who knows what they're doing. You do not want to go to someone who's putting in implants, because ultimately their goal is going to be only to replace. And you do not want to replace something where 5, 10, 15 years later, you're going to be in the same problem of wanting to getting that out. You want to go to someone who is extremely transparent. When I use the word transparent, means they're showing you the high definition videos and pictures of the chest wall showing complete removal of the entire implant capsule. Because if that's not done, the surgery was never done. And this is true not only for me, but all the other surgeons. If you go to 1,000 plastic surgeons, 950 of them, 975 of them don't want to even hear the word breast implant unless and do explant alone, for example. The word en bloc is like a bad word in their eyes, and this is where you want to ask the surgeon, point out blank, what do you think you should do? Don't tell them you want an end block or an explant. Because if they're not voluntarily telling you you need an explant and done in the manner where the entire capsule and implant must be removed as one system in an end block fashion or 100% total capsulectomy, and that the capsule is sent to pathology to rule out that rare lymphoma, rule out breast cancer, rule out that very rare BISCC, if your surgeon is not sending the cultures to microbiology, if your surgeon is not returning the implants, if your surgeon is fixated on the aesthetics and a lift and be done in an hour and a half or 2.5 hours along with a lift, that you know with absolute certainty your surgeon is not focused on the explant. In my practice, it takes 4 hours for me to doing just an explant alone, no lift, and most of my patients are very pleasantly surprised that they do not need the unnecessary drain and they do not need the unnecessary lift. And this is where you join a Facebook group page and you see your surgeon who is very proactive, absolutely not putting in implants, speaking about breast implant illness and other problems that the implants cause, is very transparent about showing the high definition pictures and videos. Average length of the surgery is plus minus 4 hours, is preferably not touching the breast tissue and not doing unnecessary drains, and the entire pathology capsular tissue is being worked up and systematically, thoughtfully removed. It is one thing to cauterize the capsule and saying that the job is done, which is wrong and incomplete. In my practice, I physically remove the entire implant and capsule such that there is no second guessing the process. And the surgery is done with all due sincerity, respect, humbleness, and the pictures ultimately show and prove to you that it was done in the manner as described.
Another question, Dr. Khan. Is there any special imaging that you require to rule out any silicone in the lymph nodes before explant?
So this is up to you. If you feel a mass in the axillary area or up in the head and neck, you have to go to the head and neck surgeon or the breast surgeon to get that worked up, because you have to always be thinking breast cancer. Now, if this is one of the superficial lymph nodes and there's only one out of like the 20, then you can certainly get it, do what is an excisional biopsy. That means to remove it, it's right there. So one patient had a 1.3 centimeter lymph node on the side that was palpable. They removed it in its entirety. They ruled out breast cancer and they said, well, there's silica in it. Now, this is one of those things where your breast center has to be on top of it. Now, this one patient that I saw today that had a history of rupture, and there is silicone that extravasated into the chest above and below the muscle, she absolutely needed to get an MRI so that I would know if there's any silica pockets that are hiding in the bottom and the periphery, above, below, so that I can get it all out, because the patient has had 6 surgeries. Now, I do not mandate anyone to get a mammogram. As you can see, the mammograms are very uncomfortable for some of the patients who have capsular contracture. Now, I leave it up to your medical doctor and to your primary care physician and the breast center to appropriately screen you for breast cancer. In the majority of the cases, the breast tissue is above the muscle, which I never touch. As I mentioned earlier, I'm always below the muscle. So I do not go into the breast tissue. I do not remove cysts or masses or whatever, because this is a job that your doctor needs to have done regardless of the explant surgery. So the bottom line here is, the only one time that I would have you get an MRI is if you have history of spillage of silicone into the breast chest area and there's concerns for silicone pockets that may have been walled off by the surgeon. And for me, I must address those pockets, so I must remove those silicone granulomas or masses given the history of the previous rupture. But I will not mandate a mammogram or MRI simply because the patient may choose not to, because it might hurt, cause problems. It has been reported, as you saw earlier, mammograms have been known to disrupt the implant, be it saline or silicone, or cause hurt and harm. And I leave it up to you and your doctor to make sure that you're appropriately screened for your own good.
Does insurance cover explants?
So this is extremely important. If your insurance does not believe in breast implant, unless there is no ICD-10 code, no insurance will willfully say that we do cover it. If they do, they're only going to pay just for the removal of the implant, which probably be a 60-90 minute surgery. No surgeon will accept insurance and spend 4 hours, because the amount that they're going to get reimbursed is going to be $600, $800, $1,200, and it will not justify the 4 hours of surgery. Now remember, this is a surgery where most of the surgeons don't want to spend much time dissecting off of the rib because it's too invasive, too lengthy. And this is where your surgeon does not and would not want to even believe in it, because in the time that it takes me, for example, the 4 hours to doing a proper explant, they could have done definitely three, maybe four augmentations. And so the point here is this surgery is all about the time, the commitment, the sophistication, the etiquette of doing the proper explant. No insurance will cover the explant. If your surgeon is taking insurance to cover, with 100% certainty, you will not get the proper surgery because the surgical reimbursement for that procedure will be too shabby for the surgeon to justify his existence in the clinical setting, where it is cannot justify the 4 hours of surgery, the amount of reimbursement.
Does BII mimic lupus?
So this is a good question. It says causes autoimmune problems, right? So BII mimics lupus, MS, rheumatoid arthritis, Lyme disease, any of these quote immunological factors, right? And this is where most of these are the rheumatological joint problems, and this is not uncommon. Where my patients that have come to me, the most common top 3 subspecialists that they have seen are the rheumatologists, and maybe the allergy immunologists. Now, some small subset would have seen a cardiologist for palpitations. They've definitely seen a dermatologist for their rash. They have seen ophthalmologist for their dryness of the eyes or Sjogren's type syndrome, or they have seen a breast surgeon for these masses, whatnot else that they may have had, or other plastic surgeons. And so it is not uncommon for my patients to have seen multiple subspecialists in order to figure out why, some patients have had chronic pain issues and they have neck and back injections, or they have orthopedic issues because of the capsular contracture and now their shoulder is frozen because they cannot move their arm and shoulder because it is so hard and a mass that is stuck onto the chest. So this is where the patients have gone to all these subspecialists, and unfortunately, if not all, most of them dismiss my patients.
What labs are needed before surgery, and is a clearance needed from a person's primary care physician?
So this is a very good question. All of my patients that come to me require a medical clearance. Now, this is where your doctor has said your iron levels are good, your thyroid is good. If someone who has a hypothyroidism, they will mimic symptoms of hair loss, headaches, weight gain, joint problems. So you want to make sure your thyroid numbers are good before you even come to me, regardless of the explant. You do not want to be on the operating room table and now you're having arrhythmias, for example, right? If you have hypothyroidism, you will have arrhythmias for that reason. If you have low iron, you're going to be fatigued and a lack of energy. You want to make sure that you're optimized from the surgical perspective as well. You want to make sure that your doctor is going to take the responsibility to clear you, so that when you come to me, and 80-90% of my patients travel to see me, I know that your doctor has done all the labs, your doctor has done the right check and balance. So as you come to me, I have the peace of mind that you're doing good. Now, these are real patients. I talked to a patient from this weekend. She's in Honduras. And these are nice people, Americans. And I told them, unfortunately, I do not trust any of Honduras medicine because their labs are different, their numbers, the labs are calibrated different. If someone is coming from Germany, Switzerland, like they have come in the past, I've certainly taken that very well because, that medicine is certainly up to the standard. But someone who's doing a clearance from Honduras, there's a big question mark in regards to the validity or the numbers, and I would not be able to make much sense of that. There are patients that have come to me around COVID and they just had a COVID infection 2 weeks ago. I canceled the surgery, even though I had a clearance. And my anesthesiologist or my CRNA team, between them who review the chart independently of me, I review it independent so that we both are looking out for the patient and ultimately our patient's safety, best post-op course, intraoperative course is determined so that the patient gets the best experience. Remember, this is the most important part, so that as you come and travel long distances, we know with absolute certainty that you're in good, sound, optimal health. There was a patient last week from West Virginia. Her primary care doctor said, "You're not good for outpatient surgery at the surgery center that we were at." And automatically the patient was canceled. She was scheduled for the latter part of January for her own good. And I did not want to even do her at the hospital given the multiple comorbidities, and for her own good, I chose to cancel her altogether. We gave her all her money back because there are patients like that I choose not to operate on. There was another patient that I talked to over the weekend on Saturday morning, and by all means, please reach us for a complimentary free consultation. I do this a lot so that I can learn, help spread the knowledge. Last year, we did I think 3 or 2 kind of giveaway surgery days. What I'm doing now is I'm doing free consultations, so that you can learn more about me. Absolutely spread the word, share the knowledge that you have, so that you can educate the next patient. Now remember, this is not my opinion, this is hard objective evidence. And so that when you do get the clearance, you know that you're clear. One patient came to me 3 years ago. She was on 5 liters of oxygen and she was cleared by her doctor. Absolutely, the patient was canceled and she had to be done at the hospital. Another young nurse, 42 years of age with COPD, she had to be done at the hospital. Another nurse, BMI of 44, had to be done at the hospital because BMI of 35. So anytime it crosses my mind that the patient is not optimal for the surgery center, we always go, and our own and best interest is the patient. And the medical clearance is given by the doctor or the cardiologist that tells me that the patient has been checked and patient's optimized and is low risk for surgery. Just like you would had you had gallbladder surgery or hernia surgery or knee replacement, I mandate that every patient gets a medical clearance. There was this one patient last week that came to me from California, and this Kaiser Permanente is this hospital system out of the California region. They are, I use the word, not fair in not giving my patients the medical clearance because they don't want the patient to go out of their medical system. I think it might be a financial thing. They should optimize the patient and clear the patient so that they can choose to get elective plastic surgery or explant surgery. And they should step up. But again, they want the patient to stay within their own system. And I take it upon me to review in that very small subset of patients. But again, this is where the medical clearance is determined by your doctor. There was a patient last week who was cleared and she never had an EKG by 61 years of age. And so we mandated that this patient at least should get an EKG just to be complete, and this is something the primary care doctor should have stepped up. Another thing I must mention, this one patient came from far away and she just went to a local urgent care, and the physician assistant literally in 10 minutes cleared the patient. I said, we don't accept something like this. This is suboptimal and not the standard of care. And we made her go to a real doc who saw and evaluated the patient and got a full set of labs and determined. So this one patient that's coming from Honduras, I told her, come here, go see a doc that will do a full set of labs. You should come back in 24 hours. And when the MD evaluates and clears you, we have the peace of mind, confidence that we're going to proceed with surgery safely so that there is no turbulence, surprises on the surgery day or afterwards.
Okay, the last question. Can implants affect thyroid or hormone levels?
So this is a very good question. Now remember, they're telling you it causes autoimmune problems, right? The black box warning. Now, there are millions of patients who have Hashimoto's, for example, which is hypothyroidism, and they do not have implants. There are millions of patients who have implants and don't have Hashimoto's. So there is no direct causation and effect of having implants and getting Hashimoto's. Now, this is something where we need to do more research and understand. If you look at the MD Anderson study that was done by Dr. Clemens, where they looked at 100,000 patients, and this is a study of studies, they found not my words. This is just objective evidence, and this is a study of studies where they looked at multiple studies and they grouped together these 100,000 patients, 80,000 with silicone implants, 20,000 with saline. And they concluded that in these patients who had 100,000 implants, they studied them and they said they had 6 times higher chance for getting rheumatoid arthritis. That's a big deal compared to the general population. 7 times or so more scleroderma, 8 times more dryness of the eyes. Now, these are real studies. They also reported that there was 4.5 times higher chance for miscarriage. Now, this is where this is a study of studies. It has its drawbacks, but these are strong, I use the word associations, by a major hospital system of the United States, right? Which is the MD Anderson Cancer Center in Houston. Many state that that's the number 1 or number 2 after Sloan Kettering in New York. Now, the bottom line here is it's not a small study out of a small community hospital in the middle of nowhere. These are strong observations, and they're telling you on the black box warning causes autoimmune problems, joint pain, amongst others. And the bottom line is we do not have that direct association between the two, and more research needs to be done. Ultimately, another way to look at it is if someone has rheumatoid arthritis, they should not be getting implants. If someone has MS, multiple sclerosis, they should not be getting implants. If someone has underlying autoimmune issue, they should not be getting implants. It's basically high risk for them. And this is where one needs to understand the implications behind implants and the hurt and harm. I'm going to end with this on my end. It says on the black box warning, quote, patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others. Others means everything else. If you go back to my questionnaire, you will see from fatigue, brain fog, GI problems, rashes, heart issues, neck, back, musculoskeletal issues, almost all the organ systems of the body, all 14, they are somehow affected. In some patients, it's the hair loss. That is a significant factor for them, and no other complaints, for example. Now, the bottom line here is it's only ultimately the others, right? And it could be anything. Now, the bottom line here is only when the surgery is done properly and it's done sincerely, only then you will know that you are expected to have that recovery. So many patients ask me, I have Hashimoto's, do you think after the explant the Hashimoto's will go away? And I say, very, very, very unlikely not, right? Now, there are patients with underlying rheumatoid arthritis and they have implants. And there are patients, we do not know how much is the contribution from the implants and the autoimmune problems, how much of it is the rheumatoid arthritis. And even if they improve 20-30%, that is an improvement, right? And remember, anyone with rheumatoid arthritis should not have implants, if you ask me. And they tell you that there's a higher risk, problems, more issues. And those patients should get an explant if they have underlying rheumatoid arthritis or MS. And they have implants, they should certainly get an explant. So having said this, please continue to ask questions. Please follow me. I get this question asked a lot. Join my Facebook group page, which is the private breast implant analyst support group page by patients. Remember, this is an open platform. Many of my patients talk to another one, DM independent of me, and I have no idea what they're talking about. So essentially, this is a free independent platform for them to learn more about me. Remember, this surgery is about me doing the surgery, right? And this is where you have to have that faith in me. You cannot just go to another surgeon and expect them to do the same as I do. This is like you're doing a nose and another surgeon does a nose. No one can copy it. Same thing. This is my fingerprint as to how I do it. If I bring another plastic surgeon and I hire him and I say, please follow me, I promise you he or she will not be able to reproduce how and what I do. May take a long time, maybe never, because it's the mindset, it's their own intuition, it's their sixth sense, it's their learning curve, it's their belief in their heart. And remember, this is where you as the patient, you have to do your homework. You have to know what you're signing up for. you have to be involved. You have to talk to the surgeon, not the nurse practitioner, PA, or the medical assistant, or the other family medicine doc who is there. You have to talk to the surgeon. You have to have the confidence in the surgeon. You have to have that peace of mind and tranquility as your surgery is done. When you put your head on the pillow, you have that nice peaceful smile because your surgeon gave you the pictures and the videos of the chest wall consistently from one patient to the next, because that is the ultimate proof that the surgery was done in the manner as described. Another question that patients ask, we have an office here in Bloomfield Hills, Michigan, and we have another location in the northern suburbs of Los Angeles, in Northridge, California. We will be there in February. We will certainly be there in April. And if needed be, we probably may open up another day in March in California. And so please follow the Facebook, listen to what the patients are saying, listen to the many Facebook Lives that we're going to do in 2026 so that you can follow along with us. Share your experience with the many others so that everyone understands what it means to have breast implants, especially those patients who have explanted, so that you can share your journey. And it is a very defined problem with a very defined surgical plan and a defined delivery of the surgical plan and a very defined post-operative course. This is Dr. Khan, Executive Plastic Surgery, Bloomfield Hills, Michigan.